Hello, my name is Shannon Brooks. I am a registered nurse and currently an advanced practice registered nurse student at Regis College. I am here today to talk about my proposed study. Do elective inductions less than 39 weeks result in higher risk for admission to the neonatal intensive care unit? Why is this important to research? The American College of Gynecology and Obstetrics recommends that elective inductions are done greater than 39 weeks gestation because the growing number of elective inductions is becoming a health factor for infants. Mothers induced through elective inductions prior to the recommended age place the infant at higher risk for health issues that could be otherwise avoided. This results in newborns having to be admitted to the neonatal intensive care unit for treatment and care. The purpose of the study is to show and compare elective versus non-elective inductions less than 39 weeks, to determine if the NICU admissions are more consistent among the infants before 39 weeks when clinically there is no reason to induce. We also like to look at the cost effective of the long hospital stays when an induction takes place, especially with women among their first child. Infant bonding that is interrupted at delivery when infant is stressed out from the prolonged labor, and NICU interventions that otherwise could be avoided. Elective inductions result in prolonged labors among nulliparous women. These are women who are having their first child. Prolonged labor can result in multiple complications for the newborn. There's multiple studies around the world that have studied elective inductions and newborn outcomes, proven that the infant is at higher risk for complications and or mortality rates. Reasons newborns need interventions in NICU admissions. One of the first main reasons is maternal chorioamnionitis. This is when the mother presents with maternal fever. The infant presents with fetal tachycardia on the fetal monitor. That is a heart rate greater than 160. The mother presents with maternal tachycardia. Her heart rate is greater than 100. When this happens, the infant does have to be treated after delivery, and the mother has to be treated during her labor. Meconium can be another result from fetal distress. This is when the baby is stressed out from the prolonged labor and the baby has a bowel movement while in utero. This presents in the amniotic fluid from the water breaking, and it will come out as a green or brown tinge in the fluid. After delivery, immediately following delivery, the baby has to be brought over to the crib and not skin to skin with the mother to be assessed to make sure that the baby did not swallow any meconium on the way out. If the baby did swallow the meconium, the baby may possibly have to be deep suctioned or taken to the NICU and possibly intubated if it's below the cords. Newborn respiratory effort is another risk factor. Infants have to transition after the first 24 hours after delivery. Sometimes they can have difficulty doing this. And if there's respiratory effort problems, they become tachypenic or they tachycardic, they could possibly have to go to the NICU or be observed in a special care nursery. Maintaining oxygen saturation. Hypoglycemia. Sometimes if they cannot maintain their blood sugars, they also cannot maintain their temperature. With the saturation, they have to have CPAP and be observed for 24 hours in the NICU. Sepsis and infection is other possibilities if the mother runs a fever and other issues during labor. The Iowa model is what we used. We formed a team of APRN students We had results that had positive outcomes that helped educate doctors and nurses and mothers with this study. We also had continuous monitoring of outcomes where this could come up in the past as well and in the future to continually be looked at and observed. This could result in practice change for doctors, midwives, nurses. It will also provide guidance for healthcare providers in day-to-day practices affecting patient outcomes, as well as financial aspects. When you are not doing elective inductions, you are not having women have prolonged stays and interventions that may not be needed otherwise. Gaps to address. Gaps are defined as a missing or inadequate information that limits the ability of reviewers to reach a conclusion for a given question. We made sure to address these gaps, and we made sure that all women were nulliparous deliveries. They ended up, even if elective, resulted in vaginal deliveries and not C-sections. The length of their induction, we made sure to chart and write down. That means the onset of their labor to the second stage, that would be when they are fully dilated, to the time of delivery. Interruption of bonding, if the baby did, for any reason, have to not be skin to skin at delivery, we made sure we charted that. Infant admitted for observation for any other reasons, if it's temperature, blood sugar, or meconium, or transitioning in that first hour. How many doctors do not follow recommended guidelines, and health-related costs as well. For this project, we used methods. We had a sample size of 250 women. They did have to be in their third trimester or greater than 36 weeks. We used a qualitative study approach. Women were reviewed previous births at the same location, at the same hospital, at Social Hospital, between the time of 2019 to 2020, who have had elective versus non-elective inductions prior to 39 weeks and their outcomes. We also, for this project going forward, we used for the next 12 to 24 months, we collected data, used two cohorts. One cohort was the elective inductions, one cohort was the non-elective inductions. Also used descriptive statistics to analyze age, ethnicity, marital status, income, and education. For recruitment, we recruited women that were nulliparous, third trimester. We excluded anyone who had any gestational diabetes, preeclampsia, medical indications for induction. That would include things similar to lower high amniotic fluid, size of a baby, someone with a large for gestational age or small for gestational age. It had to be elective with no other issues with ultrasounds or diseases that were brought upon during their pregnancy. We gave the women a questionnaire at the MD office visit for their initial face-to-face interview with researchers if they were a likely participant and would like to be a part of this study. This was located in Weymouth at Social Hospital at 76 Bog Street Road and on the second floor. This study is significant to nursing research because nurses are providing the most bedside care during labor. So it most effectively does come in contact with nurses, and I can speak as an experienced labor and delivery nurse that this is something that a patient and a nurse build a rapport throughout the labor process. Infants bond in time is another subject. To not have to separate from their mothers. Financial aspects of the medical treatment would decrease. And one-on-one nursing care in the NICU always takes precedence because there is a nursing shortage. So all these factors would help with innovation for our future. It would also allow better quality care and outcomes all around. As an experienced birth and unit nurse and future women's health nurse practitioner, my goal is to advocate for my patients, to provide the best care and outcomes for my patients. I'm passionate about providing care and bringing awareness to elective inductions that result in infant risk to the neonatal unit that otherwise could be avoided. So when you are making a decision, I want you to think about this. I want you to think about your wife, yourself, your mother, your children, and your future grandchildren. Everyone deserves to have the best care with the least risk factors, and they depend on nurses and doctors to help make that decision. Thank you for your time, and thank you for taking my study into consideration for your grant. If there's any questions, I would be more than happy to answer them now.